We specifically had a question about the baseline differences. So we saw those baseline differences in the NT-proBNP, KCCQ scores, as well as walk distance in the no prior AF subgroup. How might these characteristics, do you think, help contextualize or even predict which patients may benefit most from acoramidis in a clinical sense?
Yeah, so I think that outside the trial itself, it further highlights the fact that if you have ATTR and you have atrial fibrillation, that your quality of life and your biomarkers and your functional status tend to be worse. So it's kind of an additive factor on kind of background risk. Um, but I think the data that we showed at ESC heart failure would suggest that the reduction in atrial fibrillation morbidity is reduced across both groups, whether or not you had atrial fibrillation or not. And so I think the takeaway there is that there's kind of not a too late time to start these therapies, that many patients across a broad spectrum can benefit. Certainly, we want to diagnose people earlier before they have some of these things like atrial fibrillation, but it doesn't seem like, there's a group of patients where there's beyond the point of return where they don't derive benefit from disease modifying therapy. I think that we saw pretty consistent results across these subgroups, and there's further analyses that are going to be done in this respect. And so, we look forward to sharing those down the road as well.
So with trials that are ongoing like this and post hoc analyses that you mentioned, are there any findings so far that have surprised you? And are you forming new research questions as a result?
I guess I wouldn't say surprised, but I think it was relatively unknown to me about how disease modifying therapy would perform across a spectrum of patients based on disease severity and comorbidities. And, it's certainly possible that it could be that these things are more effective in, say, lower risk and, fewer patients with fewer comorbidities, but not as effective in, those more advanced patients. But I think the data that's emerging from attribute, for example, is that there is, benefit across a wider range of patients. And so I think going forward, we still need more research to better understand how to measure disease progression and to understand which patients may benefit from adjustments to their background disease modifying therapy. Now that we have three FDA-approved therapies, I think that that's a question that's going to become more and more salient down the road.
Absolutely. What an exciting space and time to be in the world of cardiac amyloidosis. Well, thank you so much for joining us today, Dr. Alexander. An illuminating conversation as always, and really appreciate your time and being able to learn from you again.
Yeah, my pleasure. Thanks for having me.